Okay, we'll get started. Welcome to the Grand Rounds here at the Greater Los Angeles VA. During the presentation, if you have any questions, we have our Q&A box. Feel free to leave your questions in there. We also have a chat feature. Host, just want to let you guys know too, if anybody wants to speak, they'll raise their hand, and you should have access to unmute them if you want to just take their questions during the presentation. If we have any problems, I'll be able to assist with that. Right now, I'll hand it off to my colleague. Go ahead.
Thank you so much, Mondo, for I would be at a loss without you. And we are recording the session. Yes, I see the record is on. Manny, I didn't get the memo to dress so nicely.
Your office is way nicer, Reza.
Right before I jumped on, Manny texted me saying, Reza, you're going LA style for the interview. Let me just introduce you before we dive into today's topic. And before I actually introduce you, I want to introduce the session. And the impetus for this style of grand rounds was I've been to so many grand rounds where I've wondered, why am I at the grand rounds? I know this might not be a popular thing to say in an academic sphere, but I really wanted to help create a type of grand rounds that is practice changing or practice influencing. And the inspiration behind this style of grand rounds is from the Internal Medicine podcast, not the clinical problem solvers, but the curbsiders. So today I will be interviewing our esteemed guest and one of my best friends, and it will be interview style. And there will be pauses, throughout the episode, throughout the session. And please put your questions in the chat. But ideally, you'd be able to unmute yourself and ask your questions so we can hear your voice. So today's guest is none other than Dr. Trujillo. I know him as Manny. He was my closest friend in Baltimore when I was at Hopkins for 5 years. He's a Hopkins nephrologist. He did his IM residency at MGH, did his fellowship at Hopkins, and has stayed there as a faculty member. And just to tell you a little bit about Manny, that I think speaks louder than any award or recognition he's received. He's the type of person that if you befriend him, you can text him and ask him renal-related questions any time of the day. And once I texted him about a patient with a very severe metabolic acidosis, and he was watching his son, Daniel, practice karate, and he stepped out of that session to take my question. So Manny, welcome to the first of our series of modernizing grand rounds.
Thank you, Reza. Thank you for that very nice welcome. And yes, I miss you a lot here, but I'm happy always to talk to you. It's always great to get a text. So I'm always happy to get, your questions and challenges, very interesting cases that you always have.
He's being too kind right now, but anytime Manny gets a text from me, it's not to check in about how he's doing, how his wife or son are doing. It's to ask him a renal-related question. And then after I get my answer, I'm like, oh, so how is Daniel? How is Pam?
Yeah, that is true. Well, we'll see each other soon. Very soon we'll see each other.
Oh, yeah, we do have a planned date to Disney, and I can't wait for you to come out here. But Manny, before we dive into the topic today, I was just curious, what do you enjoy doing outside of the hospital?
Well, spending time with family, that's something very important. Watching my son grow, Daniel, that is a lot of fun. He has a lot of crazy ideas. So I try to spend as much time with him. Reading is another passion that I have. I enjoy reading a lot. Right now, I'm reading a book called Noise, and it's about, how do you know the data? How do you trust the data that you receive? It's a very interesting book. So those are the things that I enjoy a lot.
And I have to say, we're not sponsored by Noise, but if the author of Noise wants to sponsor this episode, we would welcome it. Manny, you said, what crazy things is Daniel into? Like what kind of stuff does he enjoy?
So right now he's into chess, which I love. I love that he's in the chess club, and he has learned to play very well. I taught him the basic movements about the pieces, but lately we have played, and he has become a very good player. So that makes me very happy. And every Wednesday, I receive an email from the chess club from the school of all the kids that they have made checkmate during that week. And he's usually there. I'm very proud of him.
Manny, I know you were recently inducted into the Miller Colson Master Clinician Academy at Hopkins. I was just curious, for young faculty like myself and others who are listening to this, trainees, what advice do you have for them to find a meaningful career? Because we know burnout is such, a thing right now for many of us. I was just curious, how do you find joy in medicine? What tips do you have for us?
I think find a topic that you enjoy. I think that's essential. Find something that makes you passionate. And that may come in the most unexpected times. Right now, I have a particular interest in onconephrology, and this just happened by answering a phone call of someone who had received checkpoint inhibitors, and a very interesting case, and I learned a lot from that. And now I am part of the onconephrology clinic here at Hopkins. So pick up the phone. That's an advice that I received when I was like in a junior faculty. Is pick up the phone. You're gonna get interesting consults and learn from all of them. And find a topic where you become passionate. I think that's a big advice that I would suggest. Also, get surrounded by mentors. Get someone who cares about you. I listened recently a lecture about mentorship, and a mentor has to be someone who brings you up. Don't let your mentor be a dementor sucking out the joy from you. So it's a very important thing to know how to choose your mentors.
I think that's terrific advice. And now the last question before we start today's topic. What is your favorite electrolyte?
Oh my goodness. I think everybody knows that by far, sodium is my favorite electrolyte. So
it would have been funny
by potassium, but sodium by far is my favorite electrolyte.
It would have been funny if you said it was calcium and I was like, okay, we're going to be talking about sodium.
You know me well. That sodium is by far my favorite electrolyte.
Today's objective is to understand the workup and management of hyponatremia through two cases. The first case, Manny will share with you all the tools that he uses. In the second case, we will pause so you can actually apply what Manny has discussed in the first case. And just so I know, Mondo, I don't know if you're listening still, but is it possible for people to unmute themselves and ask questions, or does it, I think it only goes through the chat, huh? If it only goes through the chat, maybe I can ask Christine or one of the chief residents to monitor the chat and unmute themselves when a question comes through. All right. We're going to jump into the first case. And Manny, this first case, we actually presented on the CP Solvers podcast. It was our second episode ever. And this is like 4 to 5 years ago. Robbie knows I'm really bad with the years, but I think 4 to 5 years ago. So a huge shout out to Robbie, Sharmizi, and RC, who helped launch the Clinical Problem Solvers. This is the story of a 93-year-old gentleman with COPD and hypertension who was referred to the emergency department for hyponatremia. He had 5 days of fatigue, low energy, and loss of appetite. His primary care doctor ordered some basic labs. His sodium returned at 120. Otherwise, his electrolyte panel was totally normal, including his creatinine and glucose. The PCP recommended that he go to the emergency department. So right away, Manny, what level of sodium do patients start having symptoms? What are the symptoms that you as a nephrologist screen for? And I would love to know what are the most common symptoms and if those symptoms depend on the severity of the hyponatremia.
Yeah. For hyponatremia, I worry more about how rapidly this happened, more than the level itself. I have had people who have a sodium of 105, 110, who are essentially asymptomatic. But if you have a rapid drop in the sodium, if your sodium drops from 140 to 125, 122 acutely within 24 hours, which can happen in post-op hyponatremia, that is a very serious emergency. That's something you have to take very seriously and act on it. And symptoms that can be of hyponatremia of acute hyponatremia, acute encephalopathic hyponatremia could be confusion. Nausea is something that I take very serious. Nausea could be the earliest sign of intracranial hypertension. So don't wait for a CT scan to show cerebral edema. If you have a patient with acute hyponatremia that is showing nausea, that is something that is very serious. Second thing that could be serious is if your patient becomes acutely hypoxic. Hypoxia with hyponatremia, it could be also a big emergency. So more than the value of sodium, the rate or how rapidly that happens can lead to the symptoms. If the hyponatremia occurs slowly or gradually, the patient can be asymptomatic or have very mild symptoms. And some of those symptoms of chronic hyponatremia could be, it increases your risk of falls. Patients who develop like mini mental exams and this kind of testing, they can score lower. They can be slightly confused, but they can be also asymptomatic. Far more concerning if your patient develops acute hyponatremia and they have symptoms.
Manny, that's super helpful. I actually never thought about the tempo, despite tempo being in the problem representation and me being a clinical reasoning, person. I was just curious, how can we tell the tempo? What way do you use to tell the
So the main for timing, it would be you would have to know the values. If you don't know, you have to treat it as chronic hyponatremia. And the main difference is how rapidly can you correct it. If you have a patient who just shows to the ER and sodium is 105 and the patient is seizing, but you do not know the previous value, then you have to treat it as chronic hyponatremia. If you have a patient who went to the OR and they had pre-op values within 24 hours and you have a normal sodium, patient went to the OR and then they receive hypotonic fluids, they're in pain, they release ADH, and they develop acute hyponatremia, then you can treat that differently with hypertonic and correcting that a bit quicker. But if you do not know, you have to treat it as chronic hyponatremia. Probably the other example where you can treat a little bit quicker would be if you have like marathon-induced hyponatremia, exercise-induced hyponatremia. These are people that are usually well-trained, they're healthy, they're running marathon, and as they're running, they're drinking water, and they gain weight. These patients usually, they gain 5 or 6 kilos of weight. That is just water that dilutes their sodium, causes acute hyponatremia. So in that setting, you could we need to treat them with hypertonic saline. So, but if you do not know, you have to treat that as chronic hyponatremia. And chronic hyponatremia, it's very different from chronic back pain, where it's months of pain. Chronic hyponatremia is more than 48 hours.
Manny, that's so helpful. I was just hoping you can tell us mechanistically how the symptoms result from hyponatremia, like at the cellular level. Why do people have nausea? You alluded to it, but if you can tell us a little bit about the symptoms.
If you have acute hyponatremia, one of the ways that the cell will protect itself is as you have the extracellular space diluted, the cell will try to get rid of some of those solutes acutely. So we'll try to ramp up your sodium potassium ATPase in the neurons. That will try to kick out all the sodium and try to balance it. But they cannot compete with the degree of the drop of extracellular osmolarity. So water will move inside the cells and it will cause it will cause swelling of the glial cells of the neurons. And now, you have very limited space, I have a big head, so there's nowhere anywhere to expand. So there's cerebral edema, and the symptom that could follow is nausea. And nausea further releases more ADH, and ADH worsens everything by absorbing more water, so you create a vicious cycle. So this is why it's in acute hyponatremia so important to act rapidly, recognize it, and treat with hypertonic saline. The hypertonic saline will really not increase your sodium. Your hypertonic saline will only do is decrease the cerebral edema, and therefore your hypothalamus will realize, oh, I'm hyponatremic. I need to shut down ADH, not release ADH. And as you shut down ADH, these patients will become polyuric with diluted urine, and that is how hyponatremia is corrected.
I love that. So far to summarize, we care more about the tempo and drop of sodium rather than the actual value. And if we don't have a prior sodium, which would be the only way for us to really know the tempo, and we're going to treat it, we treat it as chronic. And one of the first symptoms, or one of the symptoms, can be nausea, and you can have increased falls. And all of this is related to the cerebral edema as an adaptive mechanism that the brain takes on for hyponatremia.
Yes. Yes, that is correct. Now, a sodium less than 120 is the definition for severe hyponatremia. So sodiums of less than 120, if you are, at your clinic and you get paid, and this is your primary, you're following this patient, and all of the sodium is 120, it's reasonable to send them to the emergency room for management of severe hyponatremia, and just to know what is happening.
And that,
No,
no, please.
It may be an incorrect value. You may want to send them to. There's times that I've been very suspicious that the lab made a mistake or it's a lab error, and I just send them to so I can confirm that they have hyponatremia. So for those patients, I may want to send them to the ER to confirm the diagnosis.
I love this so much, Manny, because there are like today, right now on service, we have a patient with leukemia who has a high potassium, but the white count is 110,000. So we're thinking about pseudo hyperkalemia. In these patients, what might result in a falsely low sodium that may make, so let's say your patient has a sodium of 120, but has no symptoms whatsoever. What might cause a falsely low sodium where you're like, okay, actually go to lab and have it checked and we'll see what happens.
And sometimes it's just lab error. It's just the machine may not be properly calibrated. So I cannot think of any mechanism that there would be like an acute, like in hyperkalemia. You can have pseudo hyperkalemia for many reasons. I cannot think right now of an acute thing that would give me pseudo hyponatremia immediately. There are conditions that will have your sodium consistently low, persistently low. And this may be the first time you encounter these patients, so maybe the initial lab. I'll tell you an example. One of my lupus patients, he had a very elevated gamma gap that I had not, to be honest, paid much attention. I was very happy the patient had no proteinuria, normal kidney function. So I was happy that this patient didn't have lupus nephritis. And at the end of that visit, the patient asked me, well, what do I do about my sodium? I felt embarrassed because I didn't pay attention that it was 130. I always have hyponatremia. And my primary care told me to fluid restrict my intake of water. What should I do? And at that time, I felt a bit embarrassed. I didn't pay attention to hyponatremia. Being my favorite electrolyte, I did not pay attention to this. But looking into his labs in more detail, he had a gamma gap of almost 6 or 7. Was a very elevated gamma gap. So his total protein was around 8, and the albumin was like 3 or 4. So very elevated levels of immunoglobulins. When I sent the SPEP, there was no monoclonal gammopathy. They had a polyclonal activation causing pseudo hyponatremia. So this serum osmolarity was totally normal in this patient. And when I checked the whole blood sodium was normal.
Super helpful. So you can check the whole blood sodium, which is just measuring the sodium over water, and it doesn't account for all the protein that is increasing the denominator.
The whole blood sodium is measured directly. They are direct ion electrodes to measure the concentration of sodium. They're not influenced by the total amount of water like you do in a BMP or a CMP.
Excellent. So back to this case, Manny. So just teach us, like I'm this patient's primary care doctor. He's 93. It seems these symptoms, fatigue, low energy, loss of, it's very non-specific. It's not the nausea, the seizures, the falls, and his sodium is 120. Is this someone that you're going to refer to the ED? And should we refer all patients who we actually think the sodium value is 120 to the emergency department? Like, do you have a cutoff you use?
I think if you think the sodium is, I think yes, because it's very difficult to manage hyponatremia as an outpatient. As in the hospital, I can control how much water the patient, I can control the fluid restriction. This is very difficult to control as an outpatient. So the safest thing to do is to send them to the emergency room, particularly if this is a new value, an acute drop in, well, I shouldn't say acute, but a new value for you for hyponatremia. We're not expecting this value, and all of a sudden the patient has a sodium of 120. I think it's very reasonable to send them to the ER.
What value, Manny? Like, what if it was 126 or 125 and no prior, the last one was, let's say 6 months ago, it was 140. What value do you use for the ED? Like,
I think anything like less than 125, I would send them to the emergency room.
That makes a lot of sense.
Yeah, I think the safest would be to send them to the emergency room.
Now, here's a question I have for you. Almost every one of the patients I see in the hospital, so I want you to put on your hospital hat, has some degree of hyponatremia. Like if like normal is 135, everyone's at like 131, 132. When, like, do the majority of people need a workup for their hyponatremia, or like, when do you actually start sending all the studies that you end up recommending as a I hope you don't have a dot phrase, Manny, and because I always get the same studies from nephrology.
Well, I don't have a dot phrase because maybe that will save me some time, but I do some very similar labs. So yes, I think I see the trends, and I'm a bit biased on this because if I'm get consulted for hyponatremia, it also means that the medicine team has worked out this. So I'm a little bit biased on this answer. When I get consulted, it's because something has happened and something has been going on for a while. So I think most of the time when I see hyponatremia, I send the work.
I love that. I absolutely love that. And here's my question for you. I remember sitting next to you in a lecture, and the case I was being presented, the patient had hyponatremia, and you said, Reza, what's your first step? I said, volume status exam. And you said, no, 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 no. And you taught me something. So in this patient with a sodium of 120, like, how are you working this up to arrive at a diagnosis?
Yeah. I think the very first step that I do is I always check the serum osmolarity. First, the very first step, I want to make sure this is hypotonic hyponatremia. Because if this is eutonic or hypertonic hyponatremia, it's a very different workup and things that you have to be concerned of. Like, for example, my patient, if you have normotonic hyponatremia, you do not have to fluid restrict those patients. So it's a very complete different workup, and you send different labs for that. You have to make sure there's not elevated in proteins. You got to make sure there's not abnormalities in lipids. So the very first step is always confirm that there is hypotonicity, that there is a low serum osmolarity.
Are the majority of patients that you're treating for hyponatremia or evaluating for, are the majority of them in that hypotonic bucket?
Yes, the majority of them, yes. The only exceptions that I would say that I see frequently are patients who are on dialysis. Because remember that your blood urea nitrogen, your BUN, contributes to your osmolarity. So if your BUN is 60 or 70, you may have a sodium of 133. You may have this case where actually the sodium is low, but the tonicity, the serum osmolarity, is elevated. So that's a kind of patient that I see often, that they have an elevated serum osmolarity for their hyponatremia.
I see, and because the urea should travel freely across the membrane, so it's not really causing a hyperosmolar state not a hypertonic state. So that patient is still hypotonic with the high BUN. Is that correct?
When you correct for the BUN, so this is you have to correct for your BUN.
That's what I learned. I felt like the most common cause of isoosmolar hyponatremia is someone that has some kidney disease and then has another reason for the hypoosmolar. And then when you combine the two, they fall right in the middle, and you can get fooled by the serum osmolality.
Yes, you can have that with chronic kidney disease and hyponatremia. Yes, that's why you always have to pay attention. What are the components of your osmolarity? Pay attention to what is your glucose. Pay attention to what is your blood urea nitrogen. Another thing that you may have to consider is ethanol levels, but that's a different story.
And so then, Manny, why don't you start with volume status? That's what they teach us in medical school. All the schemas is hypervolemia, euvolemia, hypovolemia.
Well, once you confirm this is hypotonic hyponatremia, then the next step is what is your volume status? Then you want to see, well, is my patient volume depleted, euvolemic, or hypervolemic? And afterwards, just look at the urine electrolytes. But the very first step is always make sure that your patient is hyposmolar. That's a must. I have made mistakes when I rush myself on, I want to get to the diagnosis very quickly. And if you're not organized, I find that you make mistakes. And I have done those mistakes.
I totally understand. And it's easy for me to distinguish like someone who's hypervolemic, let's say decompensated heart failure or decompensated cirrhosis, from someone who's euvolemic or hypovolemic. But the category of euvolemic versus hypovolemic, do you have any tips for us? Like, how do we distinguish those?
Sometimes it's hard. Sometimes it's very hard, Glucose memory, JVP, and you can have 5 people looking at the JVP and never agree on where the level.
And have 5 opinions, right?
Yes, and 5 different opinions, and so yes, and sometimes what it turns out at the end, when you want to make the distinction, if this is hypotonic hyponatremia, hypovolemia, from maybe SIDH, and you have urine osmolarity that is elevated, and you have a urine sodium that is 20 or 30, and that's just in a gray area, maybe what you need to do is do a challenge with fluids and see what happens to the osmolarity, the urine osmolarity, and the serum sodium. So sometimes you give those fluids as a trial, as a diagnostic intervention.
Awesome. So we will definitely talk about the urine lights. We're going to clarify it for the audience. But just to recap so far, the most important thing with hyponatremia is if you know the tempo, acute onset is very concerning, more so than the degree. And the symptoms are related to edema of the brain tissue, nausea, falls, and the nausea, that was a pro I didn't know, can promote more ADH secretion. All of a sudden you're exacerbating the hyponatremia. You should always treat it as chronic if you don't know the level of, and the thing you said about the marathon, I'll tell you 99% of us, it doesn't apply to us. So I'm not going to repeat that. But now, and you know, it makes sense to me sending the serum osm to like confirm you're in the hypotonic bucket, but don't forget, in someone with CKD, it might be isoosmolar, but you got to account for that elevated BUN. Okay, Manny. So let me share a little more about the case, and then we'll get into the urine studies and why we get the studies that we get and make sense of them, okay? So we get a serum osm in this patient, and it's 245. So a little bit more than twice his serum sodium, and it puts us in that bucket of hyponatremia. I want to ask you, from both the diagnostic lens first, and then let's focus on diagnosis for a second. The studies, the urine studies, let's go one by one and explain the rationale of those urine studies and like what the findings can show. Like, what will you start with first? You taught me something with the UA and such. I'll leave it for you.
Yes. So I was in a UA. That's in the UA, urine sodium, urine potassium, serum uric acid, and if I suspect they're on diuretics, I calculate the fractional excretion of uric acid. You can use any calculator you want in the internet, in Google, but the fractional excretion of uric acid is something that I find helpful. And the urine osmolarity will tell you a lot of information. The urine osmolarity will tell you if there is ADH or there is no ADH. And by no ADH, I mean, if your urine osmolarity is less than 100 or 150, that means your ADH is suppressed. And very few things will give you hypotonic hyponatremia with a low urine osmolarity. And that would be acute water intoxication, tea and toast physiology, or but those are the two main ones: acute water intoxication or tea and toast, low solute intake, tea and toast physiology. Now, if urine osmolarity is elevated, you have to go to a way other differential diagnosis. That means that ADH is present. And then you have to see if this is appropriate or inappropriate. Is the patient volume depleted, not volume depleted? And then do the diagnosis for the exclusion of SIADH. The UA, what it helps you is that the urine osmolarity at Hopkins takes about 6 hours to come back. And in 6 hours, people are tempted to do many things. The ER will give fluids, and everybody's tempted just to click on the fluids. But an initial lab value before fluids are given is very helpful. And the UA, what can help you is the specific gravity. Specific gravity is just how much density the more the urine has than water. And the value that you get a value is 1.0, and then you get 3 or 4 numbers. The value that is isosmolar to plasma is 1010. And what I tell the fellows and residents here is ignore the first 2 numbers, and the last 2 numbers, you multiply them by 30. So that's a quick surrogate of your urine osmolarity. So if your specific gravity is 1.010, 1010, your urine osmolarity is 300. If your specific gravity is 1.005, your osmolarity is around 150. If your specific gravity is 1.020, that is almost 600. The things that you have to be careful is if your patient, now everybody's on an SGLT2 inhibitor. SGLT2 inhibitors, they can increase your specific gravity. Another thing that can do that falsely is contrast. If your patient receives IV contrast, you will see a specific gravity higher than 1.040. Humans cannot concentrate that urine that much. Maybe the rats of the desert can concentrate the urine osmolarity like 1,200 or 1,600 milliosmoles per liter. Humans don't do that. So if you see a specific gravity of 1.040, you can almost bet with your friends that the patient received contrast in the prior hours.
Well, you know, man, I have 2 comments here. One is that at RVA, the urine osm results in 5 hours, so we're 1 step ahead of Hopkins and Baltimore. And the second thing I want to say, I'm not even joking. I was at Morning Report the other day, and they had a urine osm that was like almost 300. And I said, hey, I bet you guys that the specific gravity on the UA is 1010. The last two digits times 30. And then they're like, they looked at the UA, the specific gravity was 1010. And then the room was like, oh, I was like, yeah, I learned from Manny the best. The question I have for you, okay, so if we go back, the patient's hyponatremic. The first objective data you want is a serum osm. Most often we fall in the hypotonic bucket. Don't forget to account for the BUN because that can misguide you. Once you're in the hypotonic bucket, an easy way to tell what that urine osm is using those last two digits, not the first two, but the second two, and multiplying it by 30, because there's only really two conditions that can result in low urine osmolality. So if someone was like 1.005 and hyponatremic, you would be thinking that they drank too much water, for example, and the kidney is doing exactly what you want it to do, acute water intoxication, or they have tea and toast. Can you tell us a little bit about tea and toast? Why does that lead to low urine osm?
Yeah, that's a very interesting question. So they tell you in medical school that the kidney has the capacity to pee 20 liters. You can pee. That's what they teach you. At least that's what they taught you. that you can drink 20 liters and you pee 20 liters of water. That the kidney has that capacity. But that's a partial truth. That only happens if the patient is taking a high solute intake. You need delivery of solute to the distal nephron in able to be able to clear water. If you're not having a high solute intake, you cannot excrete a large amount of water. So particularly people who have tea and toast physiology, they don't have the best diet. So they're not having a large intake of protein. They don't generate a large amount of urea in the medullary region in the kidney. So they can get intoxicated with water with only 5 or 6 liters. So if you have a low intake of salt, drinking 20 liters, it's almost impossible to do. You have to be drinking 1 liter per hour, not sleep any moment, and don't pee, and the fluid that you're losing, it's almost impossible. But people who have low solute intake and their intake of osmoles is maybe about a Western diet, we eat about 800 milliosmoles per day, a typical Western diet. But if you're restricted in solutes and you're only eating tea and toast, which are carbohydrates, you're not eating anything that generates osmoles or urea. That comes from proteins. So if you're eating just tea and toast as carbs, you will be having maybe an osmolarity intake, an intake of osmoles of about 300. Then you cannot generate that clearance of water of about 20 liters. Maybe you can extract maybe 5 or 6 liters. And drinking 5 or 6 liters is extremely doable and easy for people. So these are the people that have acute, not acute, these are the people who develop hyponatremia with a low urine osmolality.
That's so helpful. And so if I'm understanding this correctly, if the urine osm is low, let's say less than 150, is it fair to say ADH is off and we think about these two conditions?
Yes, I think you would do. I would think, I think I would say maybe less than, closer to 100. 150, it's in a very gray, 150 is a number that I hate because it's a very gray area.
Okay.
But when it's in 100, it definitely have to think, lower than 100, you have to think this may be a patient who has tea and toast physiology, low solute intake, a psychogenic polydipsia. But psychogenic polydipsia occurs only if you're having a low solute intake.
Very helpful. And so if the urine osm is above what level can we say ADH is on? Not saying appropriate or inappropriate, just that ADH is on.
I would say more than 150. More than 150, the ADH is present. And the way I would think about it is if you have hyponatremia and you are euvolemic, you should not be releasing any ADH. ADH is mainly released when you are intravascularly volume depleted, more than 15% when you get the ADH release. And the second stimuli is hyposmolarity. So if you're hyponatremic, you should not be releasing any ADH. So your urine osmolality should be around 50. If you're 150, then you are 3 times what it should be. So this is how I think of that number of 150, that it sounds low. It sounds like, oh, well, my urine osmolality is way lower than my serum osmolality. But what you should think is my urine osmolality should be 50, and it's 3 times what it should be.
Totally understand. And the SGLT2 inhibitor, the contrast or hyperglycemia, does that affect both the specific gravity and the urine osm when we measure?
No, not the urine osmolality, just the specific gravity.
Just the specific gravity.
Yeah,
those things are not picked up by the urine.
No, it doesn't. It doesn't affect this. I take that back. It may affect also the osmolality because osmolality is affected by glucose as well.
Okay.
So yes, it will affect also your osmolality. It will make your osmolality higher. Yes, yes, it will.
Beautiful. So let me go on with this case because I really want to pause shortly to let the audience ask questions. Audience, please put your questions in the chat. I'm finding this extremely, extremely helpful. So Manny, he gets a urine osmolality. It's 521. And actually, I'm going to pause myself. Before we even get the urine osmolality, let's say you're the ED doctor taking care of this patient. Management wise, are you doing anything for this patient? Or are you waiting for the urine studies and the serum studies?
Well, you can send the urine studies. You will send urine sodium, urine potassium, urine uric acid, urine creatinine, so you can calculate the fractional excretion of uric acid. You add a serum uric acid to the labs, but then you have to go and see the patient. And as much as I love sodium, I love more blood pressure. So I have had cases where they tell me, hey, the pressure is 70/40, but we don't want to give fluids because they're hyponatremic. I just give the fluids, I do need to give the fluids. So blood pressure perfusion trumps everything. You should take that as a priority over hyponatremia. So if this patient we cannot told me the vital signs, but if the patient is hypotensive, I would start treating like a volume depleted person that needs volume expansion.
I understand, but let's say the blood pressure is normal. Are you going to wait for the studies to come back before you do an intervention?
Well, this patient volume status was euvolemic.
Euvolemic, correct.
Yeah, I may wait to see what do I find.
Beautiful.
If they're not orthostatic, if they're not hypotensive, they're not tachycardic, I may wait. I may not be in a rush. They're not symptomatic. I'm not in a rush to do things for doing things.
Got it. But let's say they have a little bit of low blood pressure and you want to give fluid. How much?
Yeah.
Let's say they weigh 70 kilograms, 80 kilograms. How much fluid should our initial bolus be?
Yeah. So I will give a bolus of 500 ml of normal saline. This is the time I have also particular interest in fluids.
Yes.
In hyponatremia, I avoid LR. So I know there's a lot of controversy about what fluid to use, and that maybe normal saline via tubuloglomerular feedback can impair renal function. But in hyponatremia, you need to give saline. Saline has 154 milliequivalents of sodium, 154 milliequivalents of chloride, but LR has 130 milliequivalents of sodium. So you should not use LR if your patient is hyponatremic. You should use normal saline.
And Manny, what is our worry that if, let's say, we give a lot of fluid, like too much fluid, what's our worry about like the sodium rising too rapidly? Like, have you seen cases where a liter is given to someone with tea and toast and suddenly the sodium shoots up?
Oh yeah, that will happen. If you have tea and toast physiology, you are at a very high risk of overcorrection. If you give solute to the distal nephron like saline, or you feed them, if you give them a hamburger and you feed them with something with protein, they can overcorrect. And they don't overcorrect because you're giving sodium. What you're doing is, particularly in the states of high ADH, where the stimuli for ADH was hypovolemia, once you give saline, you shut down the ADH stimuli, ADH gets shut down, and then you start producing very diluted hypotonic urine. And the overcorrection happens if you're making a lot of urine. So the thing that I care the most when these patients is how much are they peeing. And sometimes it's one of the reasons why I put them in the step down or the ICU. I need to know hourly urine output sometimes. Particularly if I have a serum of 105, something that is very low, and they receive fluids. My main question is, are they making urine? If they're polyuric, and polyuria, and this is defined a little bit arbitrary, I use like 200 mLs per hour for 2 consecutive hours. And this is what I put in my template of my consult. Please page renal fellow, if the urine output is more than 200 cc's per hour for 2 consecutive hours, because that means that the patient is at very high risk of overcorrecting. This is a patient that will become polyuric, lose a lot of hypotonic fluid, the total body water goes down, then your serum sodium goes up. So polyuria is something you should be very cautious and something you should monitor. If you're going to give fluids to a patient in the ER, always think about if the patient will become polyuric.
That's very helpful. And Manny, is there particular patients beyond polyuria, like cirrhosis or heart failure or kidney disease that are at higher risk of rapid correction?
Well, more than a rapid correction, the main patient that is at risk for rapid correction is the one that is volume depleted that you shut down ADH.
Okay.
If your patient has SIADH, let's suppose, we don't know, but let's suppose that this patient has a tumor in the lung producing ADH. Those patients are not polyuric because they have ADH. ADH increases your urine osmolarity and it decreases the excretion of water in the nephron. So you're not polyuric. Those patients are actually the ones that are easy to manage because you need to do some, you have to see how much water you're excreting. But these are the ones that overnight they will not overcorrect. I go to sleep very comfortable with these patients. I don't go to sleep very happy when the patients are volume depleted, you shut down the ADH, and they start peeing like crazy. Those patients make me very nervous. So the ones that have a volume depletion, they're the ones that make me nervous. But of all of them, we are worried because if you overcorrect, you can have osmotic demyelination syndrome. And the main risk factors for this, and this makes me extra nervous, and by that I mean I correct them even slower, are if you're hypokalemic, if you are malnourished, if you have cirrhosis, or if you have history of alcohol use. Those 4 things, and sometimes they happen all together, those 4 things makes me, I correct the sodium very slowly. And these patients, I may go 4 to 6 in 24 hours.
Why are they at higher risk, Manny, for osmotic demyelination syndrome?
It appears that the glial cells, they may be more prone to demyelination in these settings. There's some theories about B12 deficiency. It's not very well understood, but these are the 4 main risk factors that have been identified for osmotic demyelination. And I always worry with people with cirrhosis, people with malnutrition, people who are hypokalemic. They tend to have more cellular dysfunction.
Does the level of sodium matter, like where they're starting at as a risk factor for
that's a great question, and probably not, but people tend to do, if you find a sodium of 130, you may not do much, you may not feel like you were telling me in your rounds, everybody has 130, you don't push that sodium up, you don't do anything for that. But if you see a sodium of 110, you tend to do things to bring that sodium up. So more than the value is the rate of increase. But what happens in reality is if you are at 110, you feel compelled to do something to bring that sodium up. If it's 130, I can tell you how many times I have ignored it. 130 is okay, well, we'll watch it for now, but 110, you try to do something. So far more important is the rate of increase than the level where you start off.
That's so helpful. I know I can keep asking you questions about this, but I want to continue with the case. And what I'm hearing from you, something I didn't realize, is how important it is to monitor the urine output in someone with hyponatremia. Because let's say you have ADH that's appropriately secreted to maintain pressure and causing hyponatremia. All of a sudden, when you give that volume and the pressure is maintained, now sodium is going to try to go back to the normal range. You're going to dump all this excess water out, and all of a sudden sodium go from 120 to 135, for example, especially if they're peeing a lot.
That is correct. And that can be far more dangerous than the initial presentation of 125 that the patient was sent to the ER, he was feeling fine, but got sent to the ER because the lab values are abnormal. And what you have created is far more dangerous than the initial presentation.
When should we call renal? Like, let's say someone comes in with 125 and we give fluid and all of a sudden sodium goes to 137. Should I be calling renal for this?
Yeah, I think if you're overcorrecting, I think unless you feel very comfortable managing DDAVP, but I think it's a very reasonable consult for renal. We get consulted with that all the time. Basically, I mean, with hyponatremia now, we're correcting, please give some Rex. And I think it's a very reasonable consultation for renal.
And then overcorrection is like more than 8 milliequivalents, or what value?
Yes. So for people who have so people without the risk factors that we talk about, malnutrition, hypokalemia, alcohol use, and cirrhosis, the goal is 6 to 8 in 24 hours, no more than 18 at 48. Gotcha. If you have those risk factors, we go 4 to 6. There is a very nice series of Dr. Randon, an expert in hyponatremia, that he describes people who develop osmotic demyelination when the correction was less than 10 in 24 hours. So this is why we got a lot slower on these patients.
All right, one last question I have before I want to get the audience involved, because I'm going a little too slow here, but I really want them to ask questions, is with osmotic demyelination, is it true that those symptoms come on later? Like the treating clinician thinks they did a great job, but like when do you actually see the symptoms of
5 to 7 days.
5 to 7 days.
5 to 7 days. So you'll know if you did a good job in 5 to 7 days.
And no
Yes.
one is following up the charts. Everyone's gonna think they did a good job in the moment.
Everybody's looking for this quote.
Until Manny is the expert on the legal case. So I want to open it up to questions. If I can have our chief residents review, are there any questions in the chat? Let me take a look here. Oh, okay, so no questions, which means that either we're doing a good job or we're doing a really poor job. That being said, let me continue with the case. So we get the urine sodium, it's 102. And the urine osm was 521. So the urine osm is telling us that ADH is on. The patient does not have hyperglycemia and is not on an SGLT2 inhibitor. What does the urine sodium tell us of 102? So we know ADH is on. Now we want to say, is it appropriate or inappropriate? What does this urine sodium tell us?
Yeah, this tells us that probably unlikely to be intravascular or effective volume depletion. So this patient unlikely to be either effectively volume depleted or unlikely to be heart failure or cirrhosis or nephrotic syndrome or any of that. So low urine sodium tells you all those things, but a serum of this just tells you that it's quite elevated. And this 100 is significantly elevated. This is actually interesting. Because your urine sodium usually will be what you ate the day before. And the sodium here is in milliequivalents per liter. So assuming that this patient is being like maybe 1 to 2 liters per day, this is about being 200 milliequivalents of sodium. And 200 milliequivalents of sodium, to convert them to milligrams per deciliter, you have to multiply by the molecular weight. And the molecular weight of sodium is 23. So if this patient is being 2 liters, it's excreting about 5 grams of sodium. So it's being a lot of sodium. So this is a condition where this patient may be losing a lot of sodium in the urine.
So when you say that the urine sodium is usually low, maybe less than 10, when you have low effective arterial blood volume, what's is it all aldosterone related?
Yes. Yes, so that's mainly aldosterone related. So your low urine sodium comes as a consequence of the decrease. Is two mechanisms. The lack of stretch of the afferent arteriole leads to the release of renin, and renin will produce the release of angiotensin 1 and angiotensin 2, and angiotensin 2 will produce vasoconstriction of the efferent arteriole. Now, the second effect will be once you have caused vasoconstriction of the efferent arteriole, you restore GFR there. But in addition, if you're volume depleted and you're filtering less sodium will be delivered to the macula densa. And this increases the release of angiotensin 2, further causing vasoconstriction of the efferent arteriole. So this is mainly mediated. Low urine sodium is mainly mediated by aldosterone. There's one exception, and this is one that you have to be very careful. If you have a low urine sodium, you can almost say, yeah, this is effective volume depletion, except if my urine is diluted. So let's assume that you have given a bolus of fluids and the patient is now polyuric and it's being like crazy, 300 cc's per hour. I can bet that if you measure at that time my urine sodium, it will be less than 10. It does not mean your patient is volume depleted. The patient is polyuric because there's no more ADH. The patient is being diluted urine. So you have to be very careful here. This is not the patient you're going to give more fluids, because then you're going to cause more polyuria and overcorrection. It will occur. So just be very careful with the low urine sodium. Most of the time, it will be effective volume depletion. Take a look at the urine osmolarity. But the low urine sodium, in rare cases like this one particularly, as you shut down ADH and they become polyuric, you will cause diluted urine. Your urine sodium will be diluted. It is not a reflection of volume status at that.
That is a pro, my friend.
Just be careful because this could be the perfect storm. You gave them fluids in the ER, and then you came maybe 4 hours later and you see the patient polyuric, you check the urine sodium because you want to see if you want to give him more fluids, and then you find out the urine sodium is less than 10, but your specific gravity may be 1.005, your urine osmolarity may be 100, and you have shut down ADH. This is not intravascular volume depletion. This is just a very diluted urine.
You know what? I did not know that. And it just strikes me to the nuances of medicine. Like we learn so much, but until you experience it and you reflect, there are so many nuances. So the urine here, the patient was hyponatremic. The serum osm was low, it was hypotonic. The urine osm was high without any hyperglycemia. So we know ADH is on. Now the question becomes, is ADH appropriately on or inappropriately? That urine sodium, if it's low, it's appropriately on because the patient has a low effective arterial blood volume.
But that decision may be a clinical one. That
Yeah.
decision would be, the decision about volume will be more clinical. Is the patient orthostatic? Is the patient tachycardic? Is the patient dry mucous membranes? You know, the JVP is low. Things like that will tell you the skin trigger is low. You know, you have to come with a clinical decision for volume status. There's a lot of things that we can do that as nephrologists in our computer with our coffee in our morning, looking at labs. But volume status, you have to stand up and get into the patient's room.
I see, because we're talking about intravascular volume, like the effective or not like total body volume. So these patients with heart failure, cirrhosis, they look like they have 30 pounds on board. But if their urine sodium is low, then we can say that their effective arterial blood volume is low.
Yes, and also that would mean that there is very bad heart failure. You know, bad heart failure or worse heart failure, worse cirrhosis, they will have a low urine sodium because that means they have all that neurohormonal activation of the RAS system. So the patient that you say 20 liters up, he will have a low urine sodium because it has so much RAS activation. It's all the way to the right in the Starling curve. It's maybe not pumping very well, hypoperfusing. So your kidneys will be reabsorbing all the sodium because they think that we are all dry, but it's just intravascular volume depletion with total volume up. So that's be careful.
Beautiful. And I think what I'm going to do, Manny, I'm going to finish out the case. I'm going to summarize what I thought the pearls of this episode were. And then I'm going to ask you to just share maybe 2 to 3 points that you want the audience to take away. Remember, most of us are non-nephrologists, and most of us don't view sodium as the most important electrolyte, me included. For some reason, I'm a huge fan of chloride, the neglected electrolyte. But we can talk about that later. So this patient's urine sodium was 102, and we knew that aldosterone, like that, the ADH was inappropriately on. We sent a TSH, which was normal, and AM cortisol was 3. We quart stimmed them. They only went up to 7, and their ACTH was low. And we learned they had received numerous prednisone doses for their COPD exacerbations. So they actually had central AI, which I know can cause SIADH-like picture. And actually the patient got steroids, and they, like, within a day or two, their sodium improved. We can't dive into that, which I really want to. I just want to share a few takeaways I have, and then I want you to share a few takeaways for the audience so we can finish on time. Is that okay?
That's totally fine.
Okay. For me, I think the 2 main pearls, one was how nausea can exacerbate whatever is driving the underlying cause of hyponatremia. And many times hyponatremia can be multifactorial, and you really got to follow it over time. You have a degree of hypovolemia, a degree of SIDH. And then the other pearl, which I did not know, and I think it's practice changing for me, is when was that urine sodium sent? Even if it's low, it doesn't mean that the patient is not having activation of the ADH. It's because they might be polyuric, and that concentration of what's coming out of the urine is low. So the timing relative to diuretic, relative to fluid is very important. And I think even if the sodium is high, realizing stuff like acute tubular necrosis, diuretics, they can make you think the patient has SIADH, but in reality, they just have ATN or they are on diuretic therapy.
Yeah, no, I agree. I think taking that away point that the low urine sodium is most of the time, and I would say 95% of the time, is intravascular volume depletion. Just be careful in that 5% that is polyuria. So low urine sodium, 95% of the time is intravascular volume depletion. Just be careful in the rare setting that you may be seeing like a patient who's correcting hyponatremia by having a diluted urine, your urine sodium could be low. And one pearl that I would like just to mention is the role of serum uric acid. And I know we didn't dive much into this for hyponatremia, but I always send a serum uric acid because what at least I teach my medical students to, when I introduce the topic of hyponatremia, I don't want to confuse them with all this because I'll be thrown tomatoes if I explain all this at once. But we tell them that SIADH is euvolemic, and I tell them now euvolemic. Imagine that you have all the time ADH activated. And when you have ADH activated, you will reabsorb maybe 1 or 2%, your volume will expand. The right atrium will expand a little bit. And as your right atrium expands, it releases natriuretic peptides. And among those natriuretic peptides, you will have a decreased reabsorption of sodium in the proximal nephron, and you will have a decreased reabsorption of uric acid. So in hyponatremia secondary to SIADH, as you have a tiny expansion in your volume that releases your natriuretic peptides, you will have natriuresis. That's why your urine sodium is not low, but you will also have an elevated urinary uric acid. So your serum uric acid is less than 4. That has a lot of prediction for SIADH, or your fractional exclusion of uric acid is more than 12. And this helps me a lot when I want to see someone on diuretics if I think they could have the SIADH.
That's so helpful, man. I realized like I confused myself when I was talking about the urine sodium. Can you explain the scenario where the urine sodium is low, but it's due to polyuria rather than and like
So
what scenario is
imagine this. Imagine that you have a patient who's volume depleted, comes with nausea, vomiting, diarrhea, and they come with hyponatremia, and the sodium is 130. And someone who's nausea, vomiting, diarrhea, hypotension, volume depletion, they will have a serum sodium of 130, urine osmolarity of 500, urine sodium less than 10. That's the starting point. And then the ER says, we're going to give him 2 liters of saline. This is not appropriate, but you give 2 liters of saline, and all of a sudden you expand that volume, you shut down ADH because they're not volume depleted anymore. And now that patient will shut down ADH. Therefore, you're going to start peeing free water. And as you pee free water, because you have more water in your urine, it will dilute the sodium. Your urine sodium will become low. Not because you have intravascular volume depletion, it is because you have shut down ADH.
I say your urine osm will be low too, huh? So
it will be low. Yes, urine osmolarity will be low. This is why I was saying that when you have a urine sodium, always take a look at your urine osmolarity to make sure, my urine sodium is less than 10, urine osmolarity is 500. Yes, this fits with intravascular volume depletion. But if I have a urine sodium of less than 10, and my urine osmolarity is 100 or 50, oh wait, this doesn't fit. It's because it's not a true urine sodium that is low because of volume depletion. It's just diluted in the urine with water.
that's
so be careful for polyuria. The second thing I would say is for hypovolemic hyponatremia, polyuria is your enemy. Polyuria is your enemy. Please be careful with that. And you need to stop overcorrection either by giving D5W or give DDAVP to shut down ADH. To stop the polyuria. You give DDAVP to mimic ADH.
You heard it first here on the new modernized version of Grand Rounds. Manny, thank you so much. I would love the audience. I'm sure they enjoyed this episode. Thank you, my dear friend. I will be texting you very shortly. You look very nice.
Very good. Thank you. Thank you very much. And thank you, everyone. I hope, if you have my email, I'll be happy to answer anything. And
I'm not going to share your phone number because only I should have access to you.
All right. Great to see you, my friend.
Bye.
Right. Thank you. Bye.
All right. Thank you, everybody. That concludes our grand rounds here, and have a good afternoon.